everyone. It's lovely to have you with us this morning. For those that haven't joined us before, I'm Nick Russell, and we're being joined today from the UK by Sue Archbold, a consultant in hearing care and cochlear implantation. Now, just before we get on to speaking with Sue this morning, a little bit of housekeeping for you. Along the bottom of your screen on the right-hand side is a little closed caption icon. This is for if you need to follow with captions. I've just got a message, just making sure I wasn't doing anything wrong. If you click on the closed captions link, you'll have subtitle option or transcript option. Subtitles come along the bottom of your screen. Transcript comes up on a panel on the side. Towards the end of the webinar today, we will be able to ask Sue some questions, time permitting. Sue, if you're happy to take questions. And we'll either use the Q&A function or the chat function. Now, last week, Q&A decided it wasn't playing nice to me. I had a few issues, so we had to divert to chat. So we'll let you know as we go along. So anyhow, straight into it, Sue, because we've only got an hour this morning. So you've been involved, Sue, in public health advocacy for hearing care and cochlear implants for over 30 years now. And in that time, you've seen the first child implanted, the first adult implanted, and at the time that was innovative and groundbreaking. And now CI has become the standard of care for children born with severe to profound hearing loss, who are identified through the newborn screening program. But however, we haven't seemed to have made the same advancements in the treatment of adults with severe to profound hearing loss who desperately need access to CI as treatment, even though the research has demonstrated huge quality of life and health gains for them. So today, Sue, I think we will start by reflecting a little bit on the history of public health advocacy initiatives for adults that have brought us to this point. What has worked, what hasn't worked, what are the gains we've made, the key learnings, and how those can all guide us to more inclusive and equitable CI programs within public health amidst a pandemic, of course. Mm-hmm. So Sue, first off, can you give us a brief overview of the history of the first CI and the development of the program you were involved in?
Thank you, and good evening, everybody. Well, it's good evening here. I'm in the UK. It's 10:30 at night, but Nick threatened me with midnight, so I'm very pleased that it's 10:30. And it's a great pleasure to be here virtually, and it might be some time before actually we can all meet up again and get on an aeroplane, but this is fine for now. As you said, Nick, 30 years, and to reflect back and what has actually happened in the cochlear implant field, I would never have dreamt of 30 years ago. I was by profession a teacher of the deaf at that time, working with profoundly deaf children. I had been a mainstream teacher, and working with profoundly deaf children just made me realize the huge impact of profound deafness, the huge impact on the development of language, on communication, and everything else that involves. So in the 80s, we were starting to hear of things happening in Australia, for example, cochlear implants, yes, and about somebody called Graham Clark working there. We were hearing that adults were being implanted and then children. And of course, the parents that I was working with were starting to hear about it too and wanting the best for their children. So along came a little boy called Michael Batt, who had had meningitis, and I was his teacher of the deaf. His mother was absolutely determined that he would have a cochlear implant somewhere. And as sometimes happens in life, things come together. Sometimes they don't, and sometimes they do. But we happened to have the MRC's Institute of Hearing Research. We had a big audiology department. Jerry O'Donoghue came from the States, who'd been involved in cochlear implants there. And we had a very determined mum. Unfortunately, of course, our NHS said, well, we're not providing cochlear implants. There's no evidence to show they work. Oh. Have you heard that before?
Oh, yes.
So that was my first taste, really, of public policy work, because we decided that, okay, if you're not prepared to do that, then we will get the evidence. So we set up a charity to fund the first 10 cochlear implants to gain the evidence. And that, as I say, that was my first taste of public policy work. And we set up the first paediatric program in the UK, which became one of the biggest in the world. And that little boy is now in his 30s with his own family and has quite a powerful job and fully independent. But those are the things I would never, ever have expected 30 years ago to have happened in my lifetime. So it's been amazing.
you know, we've come such a long way, Sue, and I think you wanted to share a little slide here. Do you want me to share your slide? I think you were talking about Michael. Well, I just,
Yes, please.
I think it was this one you were talking about, Sue.
Yes, when I was a teacher of the deaf there, and like many of us at the moment, I've been doing some clearing out, and I happened to find some diaries back into 1987, and I'd written in the diary, an awful lot of people are giving an awful lot of time to this. I wonder what will become of it. I never imagined what we'd be seeing today with cochlear implants. However, as you intimated, Nick, when we started, we've come a long way, but actually not far enough, and particularly for adults.
Yeah, and talking about adults, Sue, I mean, what, you know, first led into adults being treated with CI? Because I mean, you've talked about the impact of deafness, and it is quite, you know, it is devastating for people who have been hearing to lose their hearing. And
Yes.
in adulthood, I think, you know, I mean, people just really don't understand how devastating that is. It's isolating and it's lonely and it's frustrating, and it takes away so much of who they are as a person. So so with all that in mind, you know, what led to action to get, you know, adults treated with CI?
You're right. You're so right about the impact of hearing loss on adults, and it's really under-recognised by society, and we'll come to that in again. There was a lot of work going on there at that time about adults. There was work going on in Sydney that I referred to, but I think we should also recognise the part in history that's played. There was Bill House in the States, there was the Antwerp group, there was the Hochmeyers in Innsbruck, and of course, Graham Clark in Sydney. But I think it's timely also to recognise the adults and the parents who took part themselves, who took risks.
Yeah.
Which it's really hard to think about the risks that they were taking, Nick.
Yes, and an innovative groundbreaking treatment, you know, which is new. It's when you don't have sort of that body of evidence behind it, it is a huge risk, isn't it, to undertake?
It is a huge risk, and you're quite right to refer to that body of evidence. What it taught me is that if you're going to make changes in public health and public health funding and public health provision, then you do need some evidence, and you need to find that evidence. But you also need the people who are prepared to take the risk, like the mother of Michael Vatt, like the adults that you had here in New Zealand, for example, and the adults that we had in the UK, moving ahead and taking the opportunity to have a cochlear implant. Without the steps that those people were prepared to take, we wouldn't be where we are today or have the evidence to move forward with. But as you referred to, that huge impact of deafness on adults, the social isolation, the mental effects, the physical effects, the links with dementia that are so apparent now. And in fact, so many people don't realize that hearing loss in adults, it is in fact the #1 cause of years lived with disability over 70.
Wow.
If you went out in the street, people wouldn't know that. Sorry.
It's known as an invisible disability, isn't it?
Yes, indeed.
Yeah.
And I'm sure many people listening will be able to recount stories of people denying their deafness, of the frustrations with it. It is that unseen disability, and the impact is unrecognized, even though that evidence is growing.
Yeah. And with that, you know, in those early days, I think like Bill Baber and Ron Goody were the first surgeons, part of the first here in New Zealand who an implanted, like Florence Woodward was one of the lovely, one of the first in New Zealand to be implanted. Indeed. Over 30 years ago. So in those early days, Sue, when you were first starting out, you know, advocating, what did you find was effective in advocating for treatment in adults? And especially as new and groundbreaking treatment, you must have faced huge challenges, more so than today, because it was so innovative at the time.
The challenges were huge, and I think the controversies are really difficult to understand now. So not only did you not have any evidence, not only did you not always know what you were doing, if you're entirely honest about it, not only did you not have any funding, but you were facing huge controversies from all sorts of groups, because this was seen as a very expensive intervention. £20,000 plus the rest in our case was a huge step up, and people fought hugely against the cochlear implant programs. We actually had on our walls at the hospital and the Cochlear Implant Centre in Nottingham daubed "Death to those who kill our deaf children."
Oh my
So there
goodness.
were really serious controversies going on. Even in 2000, the year 2000, our Federation of Deaf People said that cochlear implants should be decommissioned, should not be available, even for adults. So when we think in 2020 and get frustrated by where we are, we've actually come quite a long way. Not far enough, as you'd say.
And with that in mind, I mean, it's like that type of animosity at the time and barriers. How did you actually cope with that as a team who were dedicated to getting the intervention, you know, out there? How do you manage to cope, I suppose, professionally, but also on a personal level? It must have been really, really difficult.
It was extremely difficult and really challenging. And that was one of the reasons why we set up the British Cochlear Implant Group.
Mm-hmm.
And Ellen Giles, who now many people will know listening,
Ellen.
Ellen Giles,
Yeah.
well, she was running the Manchester team while I was running the Nottingham team at the same time in those early stages. And she was one of the keys to setting up the British Cochlear Implant Group for both professionals and users to get together for mutual support, because it was very difficult. And if you can imagine you're a parent making this decision for your child, and people are really giving you a very hard time about it. That was very uncertain, very challenging times. And however, there were steps on the way. Cochlear implants make a huge difference, both to adults and children. And you did have those moments where you thought, yeah, we're sticking at it. A colleague came along the corridor in the hospital and we just implanted a 2-year-old, and she said, I have never seen or heard a profoundly deaf child babble.
Oh, wow.
She sounded like a hearing child. We'd never, ever heard that before. And people take that for granted now.
And I suppose
so those...
Yeah, I was going to say, like, that's the thing. It is life-changing technology, isn't it, really? I mean, that was what was happening at the time.
It was, and it's still happening. And I think the user groups that formed and came together were extremely important. And the sort of groups that you have in New Zealand and that we have around the world were extremely important for mutual support. And of course, do remember that in those days, there wasn't such a thing as a blog. There wasn't the internet that you could go on and have a chat to somebody else. How was it for you? And to share. Which has become very important, the sort of services that you provide.
Yeah, because that must have been hard. It's getting, like, we still struggle getting awareness out there. We're going to come to that, you know, and as
Yes.
we discuss on, Sue. But I mean, back then it must have been really difficult. We're struggling with awareness with all these tools at our disposal now. You know, how did you bridge some of those challenges back then?
About awareness.
Yeah.
Well, in a way, the fact that it was so innovative and so new played into our hands, because the press were extremely interested. So, but again, that could be very hard if you think about it for families. You've just made this huge decision to have your child implanted. You haven't got somebody else's route to follow then. You didn't go on the web and see all the stuff that we have today, all the stories that are out that are so important to share. So to go in front of the TV cameras was extremely hard. Hard for adults, but also hard for children and for their parents. The other thing about children, which is probably different to working with adults, is that it takes a long time to develop language. So you're waiting 2 or 3 years before you see the benefits of the implant. But the press were extremely interested at that time. We had a lot of press coverage. We had big thing on Tomorrow's World and so on. So that actually helped, and it helped to keep it. Something that did happen in the UK that was extremely helpful then, and I think, Nick, is about what you're about public policy. So in 1990, our Department of Health decided, after all the sort of work that you do, lobbying, a member of parliament, etc., you know, that we need a program in the UK for cochlear implantation. Our Department of Health decided to fund a 3-year trial
Right.
That was a huge step forward. And we were fortunate enough to have the MRC's Institute of Hearing Research. And what that taught us was another step on the road for the public policy work. That you needed data,
Yeah.
you needed evidence, and you needed the personal stories.
The trifecta, in other words.
Yes. Is that what you see it? The trifactor.
Yeah, because that's
yes.
Because that's what, you know, like we do know, as you said, like how important empirical robust evidence is to get new treatments in health, because that's really what, you know, governments want to see. And, you know, especially when we're asking for public, you know, tax funded programs. So,
Indeed.
you know, at the minute, you know, after 30 years of these programs being very successful and the life-changing benefits we're getting and the cost benefits of implanting, you know, that body of research is huge. But globally, there is huge differences in funding models that we've got. Like some countries are funding well, some not so well. And there is still an overall issue with awareness. So, you know, so in your experience, Sue, because you've worked, you know, with programs globally, so you know programs that are funded really well, some of those that are not, you know, for us, for example, and then about the awareness and the gaps. So while funding might be good, the awareness might not be so good, and then the uptake. So can you give us some insights into those that are doing funding well, and where they're still falling down, and what maybe other countries whose funding is lacking, and what perhaps we can do to get that funding up a little bit, a big bit?
You're quite right. Is that, you know, we have the evidence, and as I say, our Department of Health did that trial, and that really taught us a lot about what you needed to provide to be able to go on and to get continued funding, and that thankfully was successful. And what it did also teach us, which was very important, was to produce the evidence in a way that people could understand, the non-specialist could understand. Because the funders, you know, in a way that, dare I say it, even a politician can understand. So if you look around the world, people are faced with the same issues about hearing loss. And it's many of the same issues about the provision of hearing aids and the provision of cochlear implants. The great disparity. And even as you say, where you have funding in place and where you have guidelines in place, you may not actually have the access available that should be there. But what we did find, as I say, was that that evidence needs to be in a way that people can actually understand it. I always remember being at a meeting when a researcher was talking lovingly about a really intense project that she was going, research project. And I looked at the funder and said, well, would this research change your funding decisions? Well, his answer was, I haven't got a clue what she's talking about.
Oh.
And people talk about that science policy divide. That when you're actually trying to talk to the policymakers and so on, that they glaze over and don't understand. So you quite rightly talked about the disparity. We can have countries which are geographically adjacent, but which have very different access to hearing aids and to cochlear implants. There's an excellent study by Bridget Shield about hearing aids and hearing aid provision, just showing that disparity. And there seems to be so often a stigma about hearing aids and hearing loss and cochlear implants that it's very difficult to get across. You know, in New Zealand, you've done so much about awareness, haven't you?
Yeah, we're a lot, and that's thanks to, you know, the cochlear implant community coming together really well and sharing their stories, and health professionals really advocating really strongly. It's been, I think that's what New Zealand does well as a community. They've come together so well and are voicing their needs really well, but still we're still battling that funding issue. You know, I mean, we're all speaking really well, and for many of our clients, they can become quite disheartened, because to have a voice when you've got a hearing loss is challenging anyhow. You know,
Absolutely.
I mean, it's very hard because when you've got a hearing loss, you want to retreat really from society, and you sort of isolate yourself. So to have the confidence to share
Indeed
your
you do.
experience,
Yeah.
and then for everything really, for your stories to fall on, pardon the pun, deaf ears, for want of another word. I mean, it really is hard to keep going, you know, at times, you know what I mean? It's yeah, and that's hard for us down here, I have to say.
Yes, and I think that is where today's technology and the internet really can show the way, because people can join up globally. And today there is such a lot going. There is advocacy groups around the world. You know, we've got the Cochlear Implant Alliance in the States. We've got different groups around the world. We've got the World Health Organization doing amazing work that they weren't doing 10 years ago about hearing loss. So although it is frustrating, we do seem to be making some steps on the way. The World Health Organization, it should actually be it's the World Health Assembly this week, which of course is being held virtually, but guess what the World Health Assembly is talking about this week?
Hearing loss.
It won't be hearing loss. They'll be taken up by the pandemic. We were supposed to be launching the World Hearing Report this week, but that won't be happening. The pandemic is taking up all that news. So there is a considerable amount of activity going on, but which needs to be brought together in ways that we see in other disabilities, such as vision. Vision actually seems to be much more cohesive and much more collaborative as groups to move forward. Hearing loss hasn't done such an effective job as that globally, even with the internet and everything to support us on its way.
Yeah, and on that, as you said, Sue, I mean, we have still come a long way, so it's not to lose heart, you know, when you look at where we started from to where we are today. And a couple of years ago, there was a wonderful campaign in the UK. They drove a highly successful campaign in lowering the access criteria for cochlear implants for people with severe to profound hearing loss. So can you just give us an overview of that strategy and how that actually ended up being as successful as it was?
Well, in fact, yeah, looking back, it's really interesting. So in spite of the moves that are made, in spite of that exciting technology, in spite of the television programs about it, when David Cameron's government came into power and produced their first white paper, it didn't even include hearing loss.
Oh.
So you had behavioral issues, emotional issues, and so on, but hearing loss didn't even figure.
Wow.
Why? It's the issue that you were talking about before, Nick, about the lack of awareness of the impact of hearing loss and deafness. So we decided we needed to do something about it. And one of the problems was that there were so many groups involved in the deafness and hearing loss business. Do you have the same issues in New Zealand?
Yeah, I mean, there is lots of different little groups, absolutely. But, you know, as I said, the thing that I like about New Zealand, they tend to do really well, is they tend to come together quite well, I have to say, in most instances, because we are small and we are quite spread out, but they tend to work quite nicely together because it's a small community really in New Zealand. At 5 million, it's a village.
Yes, and we've got 65 million. Yeah. I mean, we've got 11 million people with a hearing loss.
Wow.
So that's more than twice your population. So we had a lot of groups that were involved, but of course, when you've got a lot of different people going to government with different messages, that's an excuse for politicians to do nothing.
Absolutely.
Which is what they like. So we decided we needed to bring them together with one voice and one message. So we formed the Deafness and Hearing Alliance, chaired by Brian Lamb. It took quite a while, shall I say?
Yeah.
But we decided to be effective public policy work in the UK. We needed to do that. I can also remember the day when he shut everybody in a room and said, "You're not going out of here until you've agreed the 3 things we're going to campaign on."
Wow.
About hearing loss.
Well, after my own
anyway,
heart, quite like that.
Yeah, exactly. And we campaigned for the action plan on hearing loss, and it had 50 iterations. But it was published with a plan and an action plan to follow it and a commitment by the NHS to fund it.
Wow.
Eventually, after 50 iterations. So that's the sort of thing that you do need to do. But out of that arose an action group for adult implantation, because in the UK we had some of the strictest guidelines for access to cochlear implants. We have the National Institute for Clinical Excellence, NICE,
Yep.
or not so nice sometimes, which happens to monitor everything that we do and access to technologies and treatments. And our guidance for NICE were extremely strict, some of the strictest in Europe, which wasn't helping. Do you have accepted criteria in New Zealand then that you all work to for adults?
There is accepted criteria in the contracts, yes, but we don't have guidelines like NICE as such that guide us.
Yes.
But I mean, I think our access criteria is exceptionally strict as well, because you've got the clinical criteria and then you've got the funded criteria. So you've got two, and it's like, while you might meet clinical need, if you would get a publicly funded one would be, yeah, because we've got really strict funding over here, and it's like what which we've been advocating for a long time to get better funding made available. I think we were looking to try and get 120 implants a year up from 40, and that's been an ongoing advocacy initiative, you know, from the trusts, and they've been working very closely together to get that. But yeah, we haven't quite got there yet, as we're still in discussions. So
because as I understand it, that baseline at 40 has stayed like that for some 10 years or so. Well, I would say it's extremely strict. So the action group, we set up the action group. We involved professional bodies. We involved the user groups. At that stage, we didn't involve industry in that deliberately, because we wanted to be able to go to our all-party parliamentary group on deafness with some independence. And we made a change plan.
right.
From where we are to where we want to, this is where we want to be. We want to change the NICE guidelines. What do we need to do? What are the steps we need to do? And guess what was the first step? No. Raise awareness, media campaigns, stories, getting it out there. In a way, it's a little bit like TripAdvisor for cochlear implants.
I like that analogy, Sue.
Well, you can do all the professional awareness that you like with GPs, but actually what'll sell an implant to another adult with a hearing loss is meeting another successful user.
Yeah.
Again and again and again. I'm sure, is that your experience too?
It is, and we, like, with some clients who've had one and would like to get two and they want to speak to someone, we've had a couple who are considering getting one and have joined actually the webinars have been really good. They've really learned a lot from joining the webinars, and then they've joined the Zoom meetings, even though they haven't got their implant yet. They've joined in on those and talking to other consumers. And I know Ellen and the team at the Hearing House are really good at introducing, you know, potential new clients to other clients to have that conversation with, for, you know what I mean?
Yeah.
It's like, and then we've got lots of videos and stuff, but it's also nice to talk to another recipient about.
Yes.
Yeah.
It's hugely important, and if you think that wasn't available 30 years ago, which is so hard for those people, and now you can meet somebody else. So to say, yeah, TripAdvisor for cochlear implants. So awareness was the first thing, but then actually working our way through. When we pulled together a series of reports written in language that the non-professional could understand, and pulling together literature reviews, so evidence-based, but also doing some qualitative research, which is giving the user story. So we did a series of reports and launched them in Parliament. And then we pulled together the evidence that would lead to the change we hoped in the NICE guidance. And that was, and another important group that we have, I mentioned the British Cochlear Implant Group before, that Ellen was key to, and both Ellen, I've talked to both Ellen and Holly before talking to you tonight, and I know Holly's very keen on awareness raising. But when we were working, so the British Cochlear Implant Group did a lot of work. We had a special edition of Cochlear Implants International about changing our NICE criteria, and we tried to keep everybody pointing in the same direction with the same message again and again and again. but with different angles. And finally, last year, we got the change in the NICE guidance. But over the several years that we'd been at that, adult implantation in the UK has doubled.
Oh, that's phenomenal.
But there's always a but.
Yeah.
Yes, it's changed. And once it gets into the NICE guidelines, then you actually manage to get funding to go along with it. So obviously last year we were actually delighted. But in preparing to talk to you, I've just been on the British Cochlear Implant Group website, and they have very clear data on there, which actually I think would be helpful for you in New Zealand to do something similar, because if you want to know anything about state of cochlear implants in the UK, British Cochlear Implant Group website. But the but is, the graph goes like this.
Yeah.
Early last year, we got the NICE guidance. And last year, the implantation rate of adults has leveled off.
Oh, you would have thought it would have continued to increase.
Yes, well, you would, wouldn't you?
Yeah.
So with public policy work, you're never done. So we need to look at that very clearly. So we've got the funding, we've had awareness. So is it because we've taken our foot off the pedal, as it were?
Yeah, you sort of get to a level and you think, oh, job well done, and you sort of sit back. And as you said, you can't sit back in any public health, with any public health initiative. You've got to continue, to better the outcomes for your clients that you're meeting.
I'm sorry, that's the message, yes. Because when I saw that, since 2012, 2013, yes, the rate of adult implantation in the UK has doubled if you look at the graphs, but over the past year, stabilized. So there's the but. The good news about that is that I also think, talking with you in New Zealand, this is a global phenomenon. I've been talking to people in the States today. I've been talking to people in Bratislava in Slovakia and so on. It is a global phenomenon. And what happens, the progress in one country can affect another one. So our changes in NICE guidance, for example, have influenced the guidelines in Belgium, in Netherlands, in Sweden, in the Czech Republic. People can take them elsewhere. And meanwhile, we have to do a bit better at home.
That's a great achievement, because really, changing the lives of so many adults who are affected by severe to profound hearing loss, and being able now to get access to cochlear implants. And that's a huge, because it is life-changing for them, who, especially since the battle for so long to get better access. And but as you said, maybe the other turn of the coin is we've got the access in some countries, but we also need to continue to work on awareness, because you need, the referrals to come in. The people are aware the technology is available, it is an option for them. And how do we address that? Because maybe there's a gap, in that sort of referral rate, as opposed to the access availability as well.
Indeed. And, I was talking to somebody today about, and I know something dear to your heart, and your next webinar is going to be about GP awareness, isn't it? Yeah. And, I'm of an age where I'm tested for many things. I'm not tested for my hearing. But so, adult hearing screening, moving on, GP awareness, that, it's not okay to become deaf as you get old and do nothing about it. It's not just part of the aging process. We need to have healthy aging today. There's a growing elderly population, of which inevitably you're going to become part of. And if you're not, that's really bad news. But if we move on, we really need people to know that there is actually something that you can do about it.
And I think, as you mentioned, Sue, when we were talking before we came on air, was when we talked about screening, it normalizes it in a sense that it is a part of the aging process, as opposed to all those other screenings we get when we get a little bit older. And then it brings it more into the public arena as well, into public health, when it becomes accepted that this is an issue for people aging, and to age well and maintain your health really well. It is imperative that you have good hearing and access to good hearing.
Absolutely, because what we haven't really touched on is that the huge economic data that we've got. about hearing loss, the economic impact on society. You know, WHO reckon that it's $750 billion a year
Wow.
on untreated hearing loss. And one of the things we did in our campaign, which was carefully thought out, was we completely changed the narrative about the cost of managing hearing loss, because funders say, oh, you know, if you tell them, it's quite scary money that the politicians will think about if you tell them only 7% of those who are appropriate for cochlear implants are having them, and you know it's £25,000 a time, then you can hear them going ching, 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 oh, we can't do this. However, if you change the story and tell them that the cost of not providing cochlear implants is bigger than the cost of providing implants, then they start to listen. And that's a very simple public health message. What we say is, we did a campaign on spend to save.
Yes.
And those spend to save documents are now in 19 languages, translated by user groups. We didn't spend a penny on it. It's not always about throwing money at it. The user groups did it through the European Cochlear Implant Users Association around Europe, changing provision, spend to save. That spending money on hearing care and cochlear implants saves society money and changes lives. What's not to like?
I mean,
any politician can understand that.
And I think even whenever some of our clients have gone to meet with politicians, you know, they had no idea beforehand until they actually met a say recipient, and you know, it really opened their eyes, and that's been really effective for us whenever clients have actually gone to meet with their MP or a minister. And I mean, I think we can't underestimate the power of that, because as you said, they don't know, and I think then whenever they get it, and I think sometimes when decisions don't go our way, it's easy to get disheartened. But I mean, as you said, you've been doing it for 30 years and it's constantly the same message over and over and over again. And you just have to keep going over and over and over again.
Sorry, yes, so sometimes you think, do I really have to say this again? And the answer is, because the other thing about public policy work is that so much of it is short-termism, isn't it?
Yes.
I'm sure you find that too. People move on, you're just getting somewhere and they move on. So the decision makers
change of government, you know, I mean, you might be getting someone with one, and then you think, well, we're going to get this over the line, and then there's a change of government and their priorities are different, and they start right back at square one again, and then the government changes again. And so
Indeed.
Yeah.
And with hearing loss, you know, it still is behind others. We've just done the figures in the UK for the amount of money that's spent on research by our government in different areas, pound per head of those affected by disability. Guess where hearing loss is? Right at the bottom.
So what would be the difference in the spend? Can you give us some examples, Sue, of the difference in spend? Have you any idea?
Oh, huge, yes. Off the top, so it's less than £1 per head affected for those with hearing loss, whereas for vision, I think it's £15 a head.
Oh my
That's quite a considerable difference. And if you're talking about cancer or you're talking about heart, then you're talking about 30, 40, £100 per head, but less than £1. So we're not doing a very good job at making that case, and need to do that better.
I mean, absolutely. When you consider that level of investment, I mean, it's just, you know, well, ridiculous, really, isn't it? You know,
it is. Yes.
And so let's change tack a little bit. We're going, because I mean, the pandemic has thrown up, you know, a big challenge for us all, I think, and it's thrown up significant challenges, but I suppose opportunities as well. So I mean, we're talking about that. So I mean, where do we even start, you know, in the midst of a pandemic where resources have been pulled and diverted into, you know, managing, you know, COVID, and, you know, so those that have been waiting for a cochlear implant, you know, are sort of, you know, in a holding pattern, if you like, you know, unsure when they're going to get their surgeries have been postponed, they haven't been postponed. How do we then advocate for, you know, I mean, I look at in New Zealand where our messaging was, in the middle of COVID, you know, you need to look after your mental health, you know, even though you're isolated and lonely, but you need to get out and still be in contact with people using Zoom. But for our clients that we're representing, they're isolated and lonely a lot of the time because of their disability. And it's
Indeed.
really hard for them to use digital technology when they haven't got their implants yet. So, I mean, it's
Indeed.
quite a, yeah.
Well, it's had the impact has been so sudden, hasn't it, Nick?
Yeah.
I mean, I remember I'm just looking here at a photograph of myself. I was in Tallinn in Estonia. We were talking about implants and developing their implant program. Again, their implant program was led by users and parents and so on 20 years ago. But 2nd of March, I'm in Tallinn. Not having a clue about how life was going to change so quickly. And if you think about it, we've had to learn a whole new language quite quickly.
Yeah.
Yeah, we've coronavirus we hadn't heard of. Who knew what PPP? Sorry, I can't even say it. PPE was. Who knew what lockdown was? Who knew what social distancing was?
All
In
new
March,
concepts.
all new concepts. Now, so actually, that's quite a lesson to us. So we've all had to get used to public health messages extremely quickly. And people have done it, haven't they? Look how you've managed it in New Zealand, a lesson to the world about how you've done it. So we've actually come to terms with that to a certain extent. We've come to terms with our daily news being filled with who knew what the R rate was?
Yeah, I know.
We've got used to looking at that. We've got used to looking at the economics. We've got used to that. So it's had a huge impact and extremely quickly. And I think that, it's going to affect funding. You've done extraordinarily well in New Zealand, but tourism is going to be hit and so on. So public health spends we're going to have to argue even harder. So how do we actually raise cochlear implants when our hospitals are looking at life and death? How do we keep cochlear implants up the public health financial agenda when we're strapped for cash and budgets are hit? And it's actually changing how services are delivered as well, isn't it, with social distancing? I was talking to Holly. Ellen was talking about how she's really enjoying doing it online. And I'll come back to the mental health bit in a second. But what I've also found interesting was, so Ellen said she's happily doing online. I talked to Kathy Berman in Sydney. Telehealth is just growing. And when I was working in the hospital running the implant program, and we used to ask about doing telehealth and doing programming at home and so on, the hospital IT department would all say, oh, no, Sue, that's just not possible. Bring a pandemic on, and guess what?
It is possible.
In 2 weeks. So all the great stuff, and we have the technology. Cochlear have great technology. We can program at home. That's happening from Sydney. It's our Southampton implant team's doing some great stuff, and people actually like it. They like being empowered. They like being in control at home of their technology and the programming. We need to put people in the driving seat and in charge of their care, and I think that's a lot of what you're about as well. So that's going on.
In New Zealand, Sue, because we're such a spread out country as well, and I think, the telehealth and the initiatives that Cochlear had put in place for service delivery, will be well taken up. And the fact that they'd already started on this before a pandemic, it was like quite fortuitous, wasn't it?
It was. So we've got it. We don't have to go running around looking for it. It's actually there, and the research is done, and people like it. People, teenagers don't want to go and sit in the clinic, and they can manage the technology extraordinarily well. It's very effective. So this is going on. And the other thing about the pandemic, you said about mental health and social isolation, and as I say, I will come back to that, but it strikes me what the user and advocacy groups have come into their own at this time. If you go on the website of the European Cochlear Implant Users Group, you will see so much information about how to manage cochlear implants during the pandemic.
I mean, and they've been really good at, They've been really good at putting the information out. You know, the resources has been phenomenal. And what I've even found talking to some of our consumers, so is that, you know, whenever we first did the webinars, I go, oh, no. And I say, well, you can just watch. We don't have to see you. It's just watching. Try it and see. And they've actually really enjoyed it. And it's been quite empowering that they've been able to follow along, be fully informed, learn something new. It has, as you said, it's been quite empowering for them, realizing that, you know, they're learning another skill and enjoying another form of communication.
And who knew? And you know, who was using Zoom? Everybody's zooming here and zooming there. So, as you say, the technology is available, and I see the user and advocacy groups just taking it on and moving on. So European Cochlear Implant Users Group did a survey within 2 days right across their 30 countries across Europe.
Wow.
The American Cochlear Implant Alliance fighting for telehealth to be, and telecare for cochlear implants to be funded in the US because it's not. So they have materials on their website. The Nordic advocacy groups do, the UK advocacy organizations, and helping with a lot of misinformation. I don't know whether you're picking that up. People concerned about the pandemic and concerned about their, are they more prone to getting
Yes.
COVID-19? Have you heard that?
Yeah, we have heard that, which I think both Bill Baber, Michelle, Neve and Holly all addressed that is not the case. So they've been, you know, getting that message out, but that has been posed by a few. And then sometimes getting concerned when surgeries come back online, will the surgeries be safe enough to undertake when they come back on? So, yeah.
And I think that's really important role. And the other issue that's coming up again and again is masks, because it masks the speech signal, and lip reading is very difficult. But for example, the Portuguese user group has just got a Portuguese company to manufacture masks with, you know, blank spaces in the front and so on. So it really is moving on. And as you said, it is an opportunity. And one of the opportunities is what you mentioned, and I am coming back to, is people are experiencing social and mental isolation in a way that they didn't think was going to happen.
Yeah, and it's been really, you know, challenging for them. And and I think that's the case where we need to say you know, this is a group, especially here in New Zealand, when we have got clients who are waiting sometimes in excess of 2 years because we've only got 40 implants. And, you know, whenever we look at the pandemic and the response of making sure we looked after people's mental health, but here's a vulnerable group of people who are by default isolated and lonely and struggle with communication. And here this is adding another layer, and we're still not addressing that need. We need to make sure that we address this waiting list and get people off this waiting list. You know, in this time of crisis, it's just, they need to have their implants and they need them sooner rather than later. You know, I mean, and that's a sort of a big thing for us to get that message out, I think, really quite strongly down here, I think.
I think so. And I think you could have an opportunity because, as I said at the beginning of that bit of the conversation, that society has actually got used to thinking about public health language.
Yes.
We've learned a lot and could be open to that sort of discussions that maybe they haven't even thought about before, or thought that taking place. So I think it could give you several openings to keep up your pressure about funding, which I know is a big thing for you, fighting for funding.
Yeah, I mean, it is a big thing, you know, down here, and that's where it's been really good to talk to you today, Sue. I think we will take some key learnings from you about how we continue to do it, and also to keep up, you know, the momentum, you know what I mean? And it's you know, because really we've been trying to get, you know, really what we want is equitable access to CI for clients, you know what I mean? And it's not equitable at the moment, really, and I think that's just unfair, you know. And I think it's you know, and how do we, what other tools in our toolbox do we need to think of, Sue, you know what I mean, to help us achieve equitable access? Or is it just keep going as best as we can with our petitions and our meeting our MPs and telling our stories and getting those cost benefit analysis papers into government and continuing with it all, you know? And it's, yeah.
I know, and yeah, you know, you've got some wonderful tools in your in your toolbox that I've seen, really exciting tools in your toolbox. One of the issues that I do see when I was looking around is the difficulty of getting the sort of very clear data that's easily, you know, there's a lot of things we don't get right in the UK, but the British Cochlear Implant Group, if you go on their website, that data over the years is extremely clear. And as I say, then like this flattening of you are immediately alerted to difficulties. That's extremely clear. If I go on your Ministry of Health website, their information about cochlear implants seems to be not exactly up to the minute. And the other thing that strikes me, I know you've had some huge successes in funding, but your baseline has remained at what, at 40 for what, 10 years?
For about you know, probably eight or 10 years now, and as you said, we get one-off fundings tend to come every financial year for us, so you know we get but that's not sustainable, you know, and it's not the best way for the programs to work, because they need to, you know, project over time, and it's not fair on clients either because they're in limbo, you know what I mean? And it's, you know, so it's not the best way to run a program. We are grateful for the one-off funding, but don't get us wrong, but it's
That's the problem. And when you look at the graphs, and for people who are listening, I've prepared a presentation that you'll load up afterwards, which has a lot of this information on and the references and the graphs. But when you look at your graphs, although your cumulative numbers have gone up over time, which is what you'd hope to see, but your numbers implanted per year go up and down according to how you've got the funding. And as you say, that's not good for planning, it's not good for building expert teams, it's not good for the long-term management, because it's not, a key thing is it's not just about access, it's about that lifelong support that needs to be there, and that's only in place if you've got sustainable funding. You're not just reliant on lurching from one to the other. Because you're quite right about those people who are waiting. It's just, we did an interview study of people who were waiting, you know, one, well, he used ruder language than I'm prepared to say on a webinar, but you know, he said, I'll have to go completely bloody deaf, lose my job, etc., before they'll give me a cochlear implant. And well, that's, apart from the social and emotional and personal things, it's actually not economic, it's economically stupid as well.
Hugely so. We've had a couple of stories recently of a couple of our clients who, you know, they were at risk of losing their jobs, you know what I mean, and it's like they self-funded because they couldn't wait in limbo, you know what I mean, because their jobs were in jeopardy. And it's like, it's, which as you said, the financial decisions don't make sense, because if they lose their job, they're needing to be on welfare and support, which is going to cost the government much more rather than implanting them. And we had a story here of quite a famous cricketer, Lance Kearns, and he said like, he went from being a $15,000 beneficiary to paying, you know, much more than that on tax the following financial year after he had had his implant, because he was back being fully employed again.
Absolutely. We had a GP who lost his hearing overnight. He wasn't able to practice as a GP. Then had his cochlear implant. Within a month, he's back working, paying taxes, and by the way, found 5 people on his caseload who he referred for cochlear implants.
Oh, well, that was, I mean, and it's a huge difference. And so Sue, finally, so before we get to the Q&A section, have you any other thoughts that you would like to share with us before we've got to take some Q&As? Have you any final sort of words of wisdom?
I think words of wisdom. Well, I'm still looking for the experts, I have to say. If anybody proclaims themselves as an expert, I think they've usually missed the point, because there is always a but in life. But with pin dropping in New Zealand, you have huge opportunities. You've got great stuff going on there. You've got great teams. You've got lots of people that I know very well, and so on. So you've got great opportunities as well. Keep going. It's about listening. It's about perseverance. It's about sticking at it. And I think that the key things that you could look for the future, because you're so good at putting those videos together, you're so good about putting the stories together. But some of that evidence, just very clearly and very simply,
Yes.
it's the, something that, and I think the thing that made me aware of that was when I had 30 years ago, I had 5 minutes with the Minister of Health, and what can you say in 5 minutes? That's the Minister, yes. So they haven't time to look at your video. They haven't time to listen to a long story. So they need that evidence and that data. And you have an opportunity in today's world. And, cochlear implants, save society money and change lives. Keep going.
Well, thank you, Sue. So let's see if we've got some questions here. Let's say it's right. I'm interested in your ideas on what, if anything, this comes from Sonia, we can do as parents to advocate for single implants for unilateral deafness caused by CMV, so my progress to the other ear.
Interesting. So looking at single-sided deafness. Yeah, looking for one implant for single-sided deafness. I'm very happy if she wants to email me about that, about the evidence that there is available and that the studies that are currently taking place, because that's a major issue that's being looked at globally and particularly across Europe. So she's absolutely right to bring it up and to see it as an issue. Our National Deaf Children's Society are doing some work about that too, which I'm really happy to share with her and share that information. And also, I'm sure she's flagging up CMV. CMV is a major issue, one of the biggest, if not the biggest, cause of deafness in children. And so many people haven't heard of cytomegalovirus. I know you're concerned with adults, but since we're talking about children, let's just flag up CMV.
Well, absolutely. And if you're happy for me to give, if Sonia emails us at pin drop, then I can do an introductory email between you and Sonia. So Sonia, please do drop me a line and I can do an introductory email between you and Sue.
That's fine.
Thank you. Now, Cedric, let's see what Cedric says. It seems that most of us with hearing loss are sharing the same experiences with the funding people. And it appears to me that the politicians are bored with all the same info that they are receiving. Do you think this is what is holding back the funding we are hoping for?
He thinks they're bored.
Well, I suppose, because it's, I wouldn't think politicians are bored. I think because, the experiences are all similar, aren't they? Because it is the same for everyone. It's an individual story, but your story is the same as somebody else's. The experiences are similar.
That's a really interesting take, Cedric, that you think, well, what, the other way to look at it, Cedric, is maybe you can bore them into submission,
Yes.
But if the stories are the same, it gives huge strength to your argument, Cedric. And if your stories are the same, it also lends a certain degree of validity and credibility to them too. So I think keep going and, as I say, bore them into submission so that they give up and give you the money.
So we've got
this, and give you the money.
Yeah. So we've got a couple of points here from another person here. So you discussed the need to produce research and use methods that people will understand, and made the point that some types of research will be completely incomprehensible to politicians. Could you talk more about the type of research that you believe is most effective?
That's really interesting. Thank you. There's the hierarchy of research evidence, and for many years you needed to have a randomized controlled trial before anybody would believe that there was any evidence worth having. But there are other research methodologies, such as qualitative research, which is where I come from, which is used in the social sciences, which has a rigor of its own. And for a long time, it was disparaged in the medical professions and so on, but I see it coming on because we can actually use these methods to find out what's really going on. And actually, randomized controlled trials are extraordinarily difficult in this field to really carry out. And what we've found is that even NICE, I was at a meeting of NICE where the chief executive was there, and he had user groups in there. And what he actually said was his scientific committee, who are very hard-nosed, when they see statistics after statistics after statistics and graph after graph after graph, their eyes glaze over. But if you present user-driven research about the issues that are really important in real life, they suddenly perk up. And he said the atmosphere in the room and the decision-making can change completely. So it can be hugely effective. And I do feel passionately, in case you hadn't guessed, that it actually should be a large part of our research evidence. The qualitative research rigorously done to find out what's really going on in users' lives. And I think that that's what's actually changed public policy over time.
Well, thank you, Sue. And I'll just take this one last one, because we are at 10:30 and I'm cognizant of people needing to get back to work and get on with their day, and also you, Sue, to get to bed. It's 11:30 with you. So this last question, we'll take this one. So when we look at innovation in different sectors, etc., what innovation are we seeing globally to bring the cost down of CI to make them more affordable for private funding?
Yeah, that's an interesting one too. Globally, people are, in fact, cochlear implants, if you look at the cost of the cochlear implant itself globally, it's different in different countries, which is been the subject of a great deal of debate globally and perhaps needs to be further looked at. But part of the cost of cochlear implantation is not only the initial price, but the long-term care. And that adds up over time. So that can be done in a much more time and cost-effective ways now, particularly with telehealth and so on. And that can actually bring down the cost. But I think you're actually right, and that's quite a political issue, thinking about bringing down the cost of cochlear implantation. Yeah. But if we can get service delivery more effective, then that is one way to do it.
Well, thank you, Sue. Well, I think it is 10:30, it's 11:30 with you at night, and I'm just so appreciative of your time, Sue. You know, it hasn't just been today having a chat, it's been a couple of weeks of planning and many Zoom meetings together, and I really just can't thank you enough for joining us from the UK, imparting your wealth of experience. We've been honoured to have you here in New Zealand at our forum last year, and hopefully you will be back at some stage in the future. And but if anybody does have any questions, as we said, please do email me, and I can do an introductory email between. Sue, you're happy for to answer those questions further on from today's webinar. And so thank you so much, everyone. Thanks for joining us. And thank you, Sue, once again. And any last words from you, Sue, before we say good night and good morning?
Thank you. I don't particularly like being put up as an expert, as I say. I'm always still looking for the expert. But what I have done is put together a presentation, some slides, which Nick's going to load up, which will provide some information for the interested reader. You can look up the references and look further. And if anybody does have a burning question, I'll be really happy to try and answer it. And good luck to everybody. I do know some great people out there, and you're doing a great job. And if it's any help, it's challenging times globally, but we do need to keep going. And I do believe we're making some progress.
Thank you so much, Sue. On that note, we are motivated, inspired, and we will keep going, and we will affect change eventually.
Indeed.
Thank you so much. Good night. And thanks everybody for joining us. And we'll have this recording up on our website with Sue's presentation by Monday for you all. So thank you all so much. Ciao. Bye-bye.
Thanks.